Good
Please.
morning, everybody, and thank you, Arup, for inviting me to this wonderful course, which has been running almost full house every year. And we've had real good faculty coming over from overseas. Last year we had David Chang, and this year we have none other than Ike Ahmed. I mean, he's a wonderful surgeon, has a brilliant mind. We'll see a lot from him. So let me just touch upon the basics a little bit to just set the ball rolling. Now, vertical chop is an efficient tool as far as hard cataracts are concerned. And where did we learn our vertical chopping from? From the guys who do it best. So, can I have the audio, please? Audio, please. Look at this man, the woodcutter, doing his chopping. Watch every step, every nuance very carefully. That's the log of wood. That's his chopper. Sharp. He's very passionate about it. And you see the care he takes. And look at the chopper. The chopper does not go more than 1/3 the length of the log. Mind you, our nucleus is inside the bag. If you've seen that video and understood it, I think I don't have to speak any further. I think that says everything. So, what the lessons we have from here? We need a sharp chopper. It's about technique and not brute force. It's chopping exploits pre-existing fault lines. You really don't have to create something over there. We need a cutting board as a resistance. The chopper goes a short distance. Remember, the chopper goes a short distance, but the chop runs till the posterior plate. It propagates. You need to allow that to happen. And in the bag, vertical chopping is more effective. Fragment edges are clean and sharp like shards of glass. Now let's do a direction check. This is horizontal, and if you look at the chopper tip, it's blunt because it's going all the way almost to the equator. That's vertical. You have a sharp tip chopper, and that would be diagonal somewhere in between. And here also we need a sharp chopper. So the basics is we're using manual forces to reduce the ultrasound energy. And the horizontal chopping, the chopper moves in a horizontal plane. And vertical chopping, the chopper moves in a vertical plane. What we have is reduced phaco time and power, reduced stress on the zonules, and reduced need for phaco tip visualization, which is a disadvantage in horizontal chopping. We won't go into all that. Lots of names have been coined, and what David Chang did was he defined horizontal and vertical chopping very clearly. Indications would be hard cataracts, small pupils, and loose zonules. Now, what we do over here is basically the phaco tip and the chopper are countering each other's forces. So the phaco tip holds up the nucleus, and the chopper is buried down. The steps would be, we use high vacuum and flow. We bury the phaco tip, impale the endonucleus, and lift the impaled nucleus anteriorly, pressing the sharp chopper tip downwards, and simultaneously lifting the nucleus also upwards. This creates a shearing force and fractures the nucleus, which propagates to the posterior plate. We need a little bit of sideways movement, and that extends the fracture all the way till the posterior plate. Now, whether it's going to be a diagonal chop or a clear vertical chop depends upon how far you place your chopper from the phaco tip. If it's slightly away, it would amount to a diagonal chop, and otherwise it would be a clear vertical chop. So we need a sharp, long chopper with a cutting edge. Now, a smaller tip could be used, sharp chopper could be used for moderately hard cataracts. Phaco tips, considerations. We need to talk about the gauge, the bevel, and the angle. Now, we won't go into any rocket science. This is not very difficult to understand. Which one of these lollies is going to be held better? The one with the thicker stick or the thinner stick? It's obvious. The one on the right is going to be held better and more firmly if you're going to pass that stick to the same depth in the two lollies. Now, if you want to go into the physics of it, well, yes, there's Poiseuille's law, which defines it. And if you're a nerd, you can look at it. A 19% increase in the radius will double the volume flow rate. So increase in radius of 22% increases the volume flow rate by 100%. That's the difference between 19 gauge and 20 gauge. So a 19 gauge causes increased flow, rapid rise of vacuum and occlusion. There's a better grip on the hard nucleus. It's like the thicker stem of the lollipop, but then there's a downside. There is a greater surge on occlusion break, which you need to be wary of. Phaco tip, well, we don't use 0 tip anymore, so it's either 15 or 30. I don't think 45 would be a great advantage in hard cataracts. Let's see a video over here. Now, this is a vertical chop where the chopper is slightly away from the phaco tip, which probably beginners would find themselves more comfortable doing. We bury the phaco tip. Now, before that, just take a look at the chopper over there. It's really a mean-looking chopper. I wouldn't use that chopper like that for my regular cases. But there is my phaco tip going into the nucleus and burying, and there I'm almost at the rhexis margin, and there I go, and lateral separation, and that chop propagates all the way to the posterior plate. This was more of a diagonal chop. The next video will be showing you a clear vertical chop. So rotate it. It's very important to have, in chopping, there is only one basic rule: the fragments must be completely separate. That is a golden rule which you must follow, because otherwise when you get into quadrant removal, it's going to be very painful with those posterior sticky fibers holding on to each other, and they're not coming off, causing a lot of energy fallout unnecessarily, and causing a lot of a lot of anxious moments for the surgeon. There you are. You must see that the chop goes all the way to the posterior plate, and you can actually either see the red glow or the posterior capsule through that. So that is about the diagonal chop. Now we will move on to the next video, which will show us the vertical chop. Now look at this case. The chopper tip is very close to the phaco tip. It's very close, and there you go. Wait for that chop to propagate, and you can feel that give. You can literally hear that give, kind of, and it propagates in the posterior. So you need to give that time. You'll have to bury that chopper all the way down and wait for that crack to propagate. It's essential to be a bit patient over there and wait for that chop to propagate. You see that? Wait for it, and wait for it, and there will be a give, and you have that two fragments separating. I think that is about. Now coming to the tip angle, you could Kelman tip has an advantage of getting buried into the endonucleus much easier because of the posterior angulation. Not absolutely necessary, but I think some surgeons find it more comfortable. It's your personal choice. Sorry. That would be with the Kelman tip. The Kelman tip goes in a bit deeper into the endonucleus and gives you better purchase on the nucleus. And that's my standard protocol: a small trench which gives us a better hole and access to the endonucleus. And there we have the same vertical chopping or more diagonal chopping. That's about all, I think. Thank you very much for this opportunity and your attention.